Welcome. My name is Mike Hindmarsh. I'm the president of Hindsight Healthcare Strategies, which is a healthcare consulting firm based out of Toronto. I'm going to be talking to you today about self-management support, a primer for doing helping patients do better care, self-care. But I want to tell you quickly about my background. Most of my time was spent in the U.S. working with Ed Wagner at the McCall Institute for Healthcare Innovation, where he and our team created the chronic care model, which is a system change strategy to help primary care improve their care for chronically ill patients. The model has become very successful and is used throughout the U.S., Canada, and the U.K., and it has 6 components that involve transforming primary care to do a better job of managing patients and preventing illness as well as managing chronic illness. I'm just going to talk to you about one of those components today, and that is self-management support. So when we talk about self-management support, there are 3 key concepts that we need to keep in mind, and that is emphasizing the patient's central role in managing their illness, using effective self-management strategies that include goal setting, action planning, problem solving, and a collaborative approach with the patient. And then we need to organize internal resources inside the practice as well as refer to community resources so that patients are receiving ongoing self-management support. There are lots of definitions of self-management. This is one I like in particular because it's concise and right to the point, and it's from Barlow et al. And it is, quote, the individual's ability to manage the symptoms, treatment, physical, social consequences, and lifestyle changes inherent in living with a chronic condition. So what does that mean? It means that the patient has 3 major tasks in terms of managing their chronic illness. They need to take care of the illness, they need to manage the emotional changes, but the one thing most of your patients will tell you is that they want to be able to carry out normal activities. They want things to be the way they were before they had their chronic illness, and this is probably the most important thing to the patient. It's important to distinguish patient education from self-management support. In patient education, typically information and skills are taught. They're usually disease-specific. There is an assumption that knowledge creates behavior change, and this is actually a false assumption that is borne out in the literature. What we know is that you can take a patient and put them through an education session and give them a post-test afterwards, and they may score 100% on the post-test, but what they've acquired is knowledge, and that knowledge often cannot be acted upon because it's not presented to them in a way that is relevant to their lives. So there's a very fascinating study done here in Ontario where a random sample of patients were chosen who were literate, that is, they can read and write, but when it came to healthcare information, while they could read it, they were functionally illiterate with being able to put it into action. So what we have to remember is that patient education is necessary but not sufficient to produce behavior change. The goal in patient education is compliance, and typically it's the healthcare professional that is delivering the intervention. With self-management support, what we're talking about is solving problems that the patient identifies as issues in their life and teaching them the skills to take that knowledge and internalize it in a way where they can incorporate it into their day-to-day life. The skills are typically generalizable across chronic conditions, so we're talking about diet, exercise, lifestyle changes, stress management, so on and so forth. The assumption here is that confidence will yield better outcomes, and that is borne out in the literature, that patients that are more confident will take better care of themselves and have better clinical outcomes. Confidence, I think, is something very important that you have to focus on when you're working with your patients, because many patients will struggle with working with their treatment plans or taking their medications properly. And so when they're struggling, they don't feel that great about themselves. They'll tell you that they feel inadequate, that they've failed, that some of them feel ashamed that they can't follow their treatment plans. It's not an issue of non-compliance. It's an issue of confidence in not being able to take care of themselves. So one of the things you want to do when you're working with your patients that are struggling is to level the playing field with them. Acknowledge that change is very difficult. Let them know that you struggle with self-management issues yourself, and that you're not judging them, and that you're there with them to work as a team to help build their confidence and do a better job of taking care of themselves. So the goal in self-management support is increased self-efficacy. We want to get people feeling better about themselves. And teachers, they can be professionals or peers. Anyone can deliver self-management support to a patient with the appropriate training. Marty Fennell and Bob Anderson at the University of Michigan have done a lot of work in self-management and self-management support. And this quote from one of their JAMA articles I think is very important for us to consider. They were talking about physicians in this article, but I think you can say all providers. And so they say, quote, "If providers view themselves as experts whose job it is to get patients to behave in ways that reflect that expertise, both will continue to be frustrated. Once providers recognize patients as experts on their own lives, they can add their medical expertise to what patients know about themselves to create a plan that will help patients achieve their goals." Again, I think this is a very important message. Patients live with their chronic illness on a day-to-day basis. They are typically in your office 0.01% of their life. So whether they're self-managing properly or not, the issue that you need to consider is what is their life like and how can you add your medical expertise so that you get an optimal partnership and a collaborative approach that produces action plan or goal setting and action planning that is relevant to the patient's life. So why do we want to do self-management support? We know from the literature that patients that are good self-managers adhere to their medications, and I think it's important to note that 1/3 of patients take their medications properly, 1/3 fill their medications but don't take them properly, and 1/3 never fill their medications. So there's a huge opportunity here for the practice to improve medication adherence for those 2/3 of patients that are struggling with medication issues. And we know that there are better clinical outcomes. Patients that self-manage better have improved clinical outcomes such as hemoglobin A1C values, blood pressure, lipid values. But I think it's fair for you to ask the question, that's nice, but what's in it for me to do this extra work with the patient? And I think there's a number of things that are in it for the busy practice. What we've seen as we've done this work over the years is that when self-management support is done on a regular basis with patients, there's less tension between the provider and the patient. I think the important thing to recognize here is that confidence issue. Once the provider lets the patient know that they're not being judged and that they will work together, there is less of that tension that is created out of that lack of confidence during the interaction. So there's much more productive interactions between providers and patients. Again, I think you want to consider a patient that's not doing well will be sitting in the exam room and thinking about all the things they're not doing well, and before you even come into the exam room, there's already a tension in the air. There's already a worry that they're going to be reprimanded. Even if you don't reprimand them, they will often hear what you're saying as a reprimand or a reminder of their inability to take care of themselves. So when we do self-management support with patients and build their confidence levels, that tension disappears in the office, and there's no power struggle between the patient. You're actually dancing with the patient rather than wrestling with them. We know that it frees up physician time because quite often someone else on the team can deliver the self-management support, so the physician should be well aware of how self-management support works and endorse it and prescribe it like he or she would any other therapy. And then they can hand the patient off to someone else on the team that is trained in doing goal setting and action planning and set goals with the patient. We know that allied health staff that engage in self-management support with patients have increased staff satisfaction, and it reduces churn in the practice in terms of people leaving the practice. There's a reduction in chaotic visits, and what we're seeing now in the early stages is that there's a potential for increased reimbursement. There are a number of health insurers around the country that are experimenting with codes to deliver self-management support to patients, and so I think it won't be too long before we see the potential for increased revenue and reimbursement within the practice. There are 9 core principles that are involved in doing self-management support with patients, and I'm going to talk about each one of these, but just as you see in the list here, they're individual-centered, it's collaborative, you respect the right of the patient not wanting to change, you set SMART goals, you get a commitment statement from the patient, you show them a behavioral menu, you measure their confidence, there's a follow-up plan, and it needs to occur in every interaction. So let's take a little closer look at each one of those. When we talk about being individual-centered, an action plan is patient-centered. It's what the patient wants to do. Now, that doesn't say that the provider's agenda isn't important. It just says that what we need to do is start where the patient is willing to start. If you were to ask your patient, what would you like to do for your health in the next couple of weeks, they will generate something that is important to them, and they will have much more likely success at achieving that because it's important to them and relevant to their life. If you impose your agenda on them, we know that they're likely to be less successful. So one thing to consider is many patients may set a goal or an action and a subsequent action plan that may not be clinically relevant to you. But if that's what they want to do, the best thing you can do is urge them on, work through it, and once they get success, then again, their self-efficacy starts to increase, and they eventually will come around to the clinical agendas that you will have. Now, with that said, the vast majority of patients will set a behavioral goal and action plan that are clinically relevant to their chronic condition. But again, just to emphasize, what you want to do is open with that question. What do you want to do for your health in the next week or two? And listen to what the patient says. Now, many people say that's a bit nerve-wracking. The patient could go on and on forever. I'm not going to have enough time to do this. There's some nice research out there that shows that when patients are asked to tell their story, 50% will finish in 1 minute, 80% will finish in less than 2 minutes. Now, that does leave 20% that will talk quite a bit. But the important part about this research study, what the researchers found, was that when the patient finished their whole story, not only did they feel heard and there's more confidence, but also the provider got more information so that they could make either an accurate diagnosis or a more complete self-management plan. So be willing to listen to the patient. Currently in Canada and the U.S., patients get approximately 20 seconds to tell their story before they're interrupted, and that is often quite demoralizing for them because they don't feel that they were heard. So again, just to recap, make sure you ask them what it is they want to work on, and don't worry, you can tell them that you have some items that you'd like them to work on, but we'll start first with their issues. The second core principle is that action planning is collaborative. Now again, if we go back to what Marty Fennell and Bob Anderson said, we're partnering your medical expertise with the patient's experience in living with a chronic condition. So we have to respect what it is that's going on in their life, even if it doesn't necessarily make sense to us. What is often common sense to us is not common sense to the patient. And so that's why we have to listen to what they're doing with managing their illness or taking their medications so that we can get a better understanding of how it is that they're struggling with these self-care issues. So this is a partnership between you and the patient. Core principle 3, respect the right of the individual to not change and acknowledge ambivalence regarding change. So if a patient is telling you they just refuse to change, that they really don't want to do anything, there's nothing you can do. At this point, you let the patient go, but keep the door open and say to them, can we talk about this next time? No pressure. Eventually, something will happen where they will want to be able to self-manage better, and you'll have your opportunity. I'll give you a personal example. In my younger years, I was a cigarette smoker, and I would often go into my primary care provider, usually with an upper respiratory infection, and he would show me pictures of black lung and tell me how, I was going to get cancer. 50% of people that smoke lifelong will get cancer. And I learned how to manage that conversation. What I would typically do is nod my head. I call it the bobblehead. And if you see your patient just nodding passively, you've probably lost them. And so you want to stop and ask them a question rather than keep talking. But I came in on one visit, and he said, Mike, you and I really aren't getting anywhere on this smoking thing. And I said, yes, and I started nodding my head. And he said, let's take a different tack. He said, I've never been a cigarette smoker, so I don't know what it's like. He said, why don't you tell me what you like about cigarette smoking? And so I thought, well, that's an interesting question. And so I told him, you get up in the morning, you have a cigarette, you haven't had one all night. It's a great way to start the day. You go out with your friends and you're at the pub and you have a cigarette with a beer. It's great. You have a cigarette after a meal. And he said, well, that's interesting. He said, I didn't realize those sort of pleasurable moments. He said, are there any bad things about smoking? I said, yeah. I said, I have yellow fingers and it gives you bad breath. And if you get a stale cigarette, you've got a headache for the rest of the day. And so he said, well, do the pros outweigh the cons at this point? And I said, yeah, they do. I'm not ready to quit. At which point he said to me, then let's not fight about this anymore. The only thing I would like to ask is each time when you come in, I'll just check to see if you're ready to quit. And if you aren't, we'll leave it at that. But if you are, I've got all sorts of things I can do to help you with that. And what that did was, again, it leveled the playing field between me and the provider. And it acknowledged the fact that, I know I should probably quit, but I'm not ready to do it. And it saves him from banging his head against a brick wall because I'm not ready to change. So you've got to acknowledge that patients that don't want to change, let them go. Now, they're actually the vast minority, even though they may feel like the majority to you. If the patients keep coming back to you, they want to feel better. So most patients are actually ambivalent. And that is, like myself, I knew I should quit smoking because I knew it wasn't good for my health. But at the same time, I wasn't ready to do it, and I was addicted to nicotine. And what he did was he acknowledged my ambivalence. He said, okay, I understand. You think you should quit, but you're not quite ready. That's okay. Ambivalence is something you can work with. We often think of ambivalence as a bad thing, but if the patient's ambivalent, they're at least thinking about behavior change and that they may want to move on some part of that lifestyle change. And you can talk to them through motivational interviewing, which would be another talk that we could do at another time, to help them understand their ambivalence and move them further along the line towards behavior change. So see ambivalence is a good thing, acknowledge it, and again, it feels that the patient feels heard and they don't feel judged. Core principle number 4, when the patient is ready to change, you want to have them set a behavioral goal and a SMART action plan. And when we talk about SMART, it's a specific action plan, it's measurables, so they can know whether they've succeeded or not. It's achievable. You don't want them to set something that's unrealistic. It's relevant to their lives, and it's timed. And when I say timed, it's timed in a short interval so that you can actually see what is going on. You don't want goals that are 3 or 4 years long. Typically, you want something that they can do in the next week or two so they can get success under their belt very quickly, and then you can take a look at where they go from there. I'll give you examples of those later in the presentation. Core principle number 5, elicit a commitment statement from the patient. I know it sounds a bit corny, but research shows that if you get the patient to reiterate their action plan to you, and you seal the deal with a handshake or maybe you sign an action plan form, that they are much more likely to succeed than if you just leave it open-ended. The other thing it does too, which is important, is it helps close the loop in terms of what their action plan is. So you may talk about an action plan for a couple of minutes. By getting the patient to repeat it back, you'll hear exactly what they're going to do and things that they may have misunderstood, and you can help do some teach back and close the loop on that conversation. If the patient's struggling with setting a goal, you can often show them a behavioral menu. And what this is there's a variety of different types. It's basically a listing of different things that they can do around their self-management, and they can choose from that menu, or it may trigger something that they want to do that's not on the menu, and they can simply write that in. These are examples of behavioral menus. So as you can see on this slide, you can say to them, we can talk about exercising, smoking, avoiding triggers, taking medications properly, diet, or write something in here that is relevant to you. This is just another example of one. All of these are downloadable and are very easy to use during the session. Core principle number 7. Once we have the action plan in place, once the goal is set and the SMART action plan is set and there's the commitment statement, we want to measure confidence. We want to know how confident are they that they can actually carry out their action plan. So you ask a very simple question. On a scale of 0 to 10, where 0 is not confident at all, and 10 is completely confident that I can achieve my action plan. Where do you fall? If the patient rates themselves 7 or better, send them on their way, and we'll talk about a follow-up plan in a minute. But if it's less than 7, you need to do problem solving with them. When we talk about problem solving, it's a very simple process that I'll show you in later slides. So again, the whole purpose of measuring this confidence is to build self-efficacy. This is a nice quote from Albert Bandura. People's beliefs about their capabilities to perform specific behaviors and their ability to exercise and influence events that affect their lives increases their self-efficacy. That quote wasn't written down quite properly. Self-efficacy beliefs determine how people feel, think, motivate themselves, and behave. Core Principle 8, follow-up. This is absolutely critical. What we know is that patients that, when they set a goal and an action plan, if they don't receive follow-up, they often felt dropped off the radar. So if I've set a self-management goal that I am going to increase my exercise, and my action plan is that I'm going to start walking a couple of blocks 4 times a week, someone needs to follow up with me in the first week to see how things went. I may have struggled with it, I may have had a hard time getting out, and that follow-up allows you to see what level of success have they achieved around their SMART goal, and you also get an opportunity to help problem solve any issues that they might be having. Now, follow-up can be a bit onerous for a busy primary care team, but there are multiple ways that it can be done. It doesn't have to be done in an in-person visit, and I strongly suggest you don't do that. Certainly can be done by telephone with dedicated time for staff to make some of those follow-up calls. The patient can email you or leave a phone message about how they're doing. Or you can assign the follow-up to a family member and have the family member follow up with the patient. So there's creative ways to get the follow-up done. But the bottom line is if the patient is setting a timed goal, you've got to follow up with them within that time. And if you do say that you will contact them, and you've got to make sure you do it, because if you don't, you'll lose their trust very quickly. Enid Hunkler did a very nice study out of Stanford University where she was having trouble with her psychiatric patients that were suffering from major depression. And she would prescribe SSRIs for them, and within about 2 weeks, most patients had dropped off their medications. So she did a fairly simple follow-up intervention. It was a randomized controlled trial. And the first part of the intervention was 3 to 4 days after she prescribed an SSRI, the team nurse called the patient. The patient would be expecting the call, and that they knew it was going to be a structured call. And the nurse checked in with, did the patient fill their medications? Are they taking them properly? And were they having any side effects, and help them problem solve those side effects? She then did another follow-up call 2 weeks later, again a structured call, 5 minutes from the nurse, to check symptom levels. And since symptoms typically aren't relieved within 2 weeks of starting those medications, reassurance that if the patient stayed on their medications, they would start to see symptom relief fairly soon. That simple intervention resulted in 100% more compliance with SSRI medications for patients suffering from major depression. I think what we can do is we can extrapolate that and say that for any patient that's being prescribed a difficult treatment regimen or medication regimen or a tough self-management goal and action plan, that quick follow-up within a few days just to see where the patient is at will improve their outcomes dramatically. And what it also does for you is it keeps the patient on their treatment plan, their medications, their self-management SMART goal in the moment, rather than failing and coming to the office at their next check back, which could be 3 or 4 months later, and the patient hasn't been doing the right thing and is struggling, and your visit ends up being longer. Again, what we see from people that do this kind of follow-up is the visits down the road are briefer, faster, because the patient's on track. Core Principle 9, self-management support needs to happen at every interaction. This is not a one-time thing that we do, and it's just as important as clinical treatment planning. So what you have to figure out is, how do you build self-management support into the clinical visit? Now, what I've seen from many teams that have been successful at doing this is often the first 10 minutes of the visit is spent doing treatment planning and medication management by the physician or the nurse practitioner or the PA, and then the patient is handed off to someone else on the team, maybe the RN or the medical assistant, to do the self-management follow-up and training. What we know is that non-physician staff are 9 times more likely to engage in goal setting than clinical staff. There's lots of different websites you can go to, and I'll talk about some of those more. But I think the focus here needs to be, rather than having a clinical visit where at the end of the visit you beg the patient to do the right thing or threaten dire consequences, and I know you don't threaten dire consequences, but we're very quick to say, you know, if you don't take your insulin properly, your blood sugar is going to get very high. The patient perceives that as a threat. We know those behavioral interactions don't work, and we do know that self-management support does work. So figuring out how to build it into that clinical visit rather than seeing it as an add-on is critical. And the reason it needs to happen at every encounter is because self-management support is an ongoing process for all of us. Sometimes we do it well, sometimes we don't. And so in the same way that you would consider clinical treatment planning an ongoing process, this behavioral intervention to help patients with their clinical treatment plans and medications needs to be seen as an ongoing process. Now, there's a very simple process here called brief action planning that was created by Steve Cole et al. Steve Cole's a physician in Texas. And what he's done is he's looked at the process of self-management support over the last 20 to 30 years as it's been developing. And he's created a very simple mechanism for doing this in primary care to keep it very brief and move things very quickly. So we start with the question, is there anything you would like to do for your health in the next week or two? If the patient struggles and doesn't know exactly what to do, they can be shown a behavioral menu, and they choose something from that. They set a SMART behavioral contract with the provider. There's the elicitation of a commitment statement. You check in on confidence. How confident are you on a scale of 1 to 10 that you can carry out this plan? If they're confident, when would you like me to check in to review how you're doing with your plan? If they aren't confident, ask them what the barriers are and help them problem solve that issue. This slide is just an example of what the conversation might actually look like. So based on the 3 core questions of brief action planning, the first one is to elicit the patient preferences and desire for behavior change. That's the question of, is there anything you'd like to do? You ask them what, where, when, how often, get very specific on that SMART goal, elicit the statement, commitment statement, I will walk for 20 minutes in my neighborhood every Monday, Wednesday, and Friday before dinner. Check their confidence level. You say that sounds great, like a great plan, but changing behavior and sticking with the plan is actually very hard for most of us. If you consider the confidence level, where do you lie on that scale? Again, less than 7, problem solve. Greater than 7, let them head out on their way and figure out what the follow-up plan is going to be. This is a very simple tool for doing SMART, setting SMART goals and action plans. So the first question, what is it you want to do? And then the detailed, specific piece. How are you going to do it? What are you going to do? When, where, and what frequency? So rather than a patient saying, I just want to work on, work on better exercise, quite often the way that interaction ends is, that's terrific. I'm really glad to hear that. And you send the patient on their way, and they go home and don't do anything. What happens in number 2 of this step is you say, that's terrific. What is it you want to do? And so the patient may say, as I said before, I'm going to walk a couple of blocks 3 days a week. Terrific. So we know the frequency. Where are you going to do it? They say, well, I haven't thought about that, but I guess I'll just do it right in my neighborhood. And how are you going to walk? Are you going to walk quickly, slowly? I'll try to walk on a moderate pace. And exactly what time are you going to do this on each day? Now, the reason I'm being so specific here is if you get them down to that level of detail, then what they're doing is tailoring the action plan to their daily activities. So they're much more likely to fit it in to their lifestyle rather than just letting them go or telling them the best way to do it. So again, you get the confidence statement. You can do a confidence or commitment statement, do the confidence rating, check their barriers, so on and so forth. I'd mentioned problem solving earlier. What we want to do is, when you're problem solving with patients, get them to identify the problem. And so I may say, well, I'm worried about walking because, I've got some bunions and they tend to get sore if I do a lot of walking. So you ask them, what could you possibly do to make sure that your bunions don't bother you? Or if they do bother you, what would you do? You get them to generate the solutions to the problems. Because again, if you suggest things, they will quite often agree with you, but they may not be things that fit into their life very well. If they suggest the solutions and pick one to work with, they're much more likely to tailor it to their lifestyle and be successful. So remember, problem solving is a process of eliciting the problem and solutions from the patient and getting them to choose what they want to do. I'll give you a brief story about how important this is. My 90-year-old mother, shortly before she died, became very frail, and she was worried about falling down the stairs. And so her provider said, well, what do you want to do to prevent that from happening? And she said, I don't know. You tell me what to do. So at that point, it's all right to offer your advice. And so he suggested we can bring in a physiotherapist for strength training. We can teach you how to slide down the stairs on your bum and climb up on your hands and knees when you're feeling like this. We could also talk about putting a chairlift in if you're able to afford that. And she said, well, tell me what to do. And he was very tuned in to self-management and motivational interviewing and said, Helen, I can't tell you what to do because I don't know what your house is like. I don't know what your daily activities are. I need you to sort of problem solve this issue and tell me what works best for you. At which point, what she did was she said, well, I don't want a physiotherapist in the house because I don't like having strangers in the house. I don't want to be sliding down the stairs on my bum in the middle of a bridge game because that would be embarrassing. She said, I know about these chairlifts. I can afford one, so I think I want to go with a chairlift. So in that process, he identified the problem. He provided advice on solutions for her, as I said, which is okay because she couldn't come up with any, but he made her choose, and she chose the one that was most relevant to her life. As he said, he never would have suggested the chairlift because he would want a physiotherapist to come in and do strength exercising, which may be more appropriate clinically, but she wouldn't have gone for it, and therefore nothing would have happened at all. So again, problem solving is very important. Now, I've mentioned before that we know from the research literature that self-management support is effective at improving clinical outcomes, and this is a very nice meta-analysis by Norris et al., where they evaluated 31 randomized controlled trials around diabetes care that incorporated self-management education and support interventions into the study. What they saw was that there was an immediate impact on hemoglobin A1C. On the left-hand side axis, that is the change in hemoglobin A1C levels. So there was almost a full percentage point impact on hemoglobin A1C levels, which, as we know from the UK PDS study, has a dramatic impact on long-term complications and outcomes for diabetes care. However, when the studies ended, within 1 to 3 months and greater than 4 months, there was a decay effect down to 0.3%. So we didn't totally lose the effect, but there was a decay effect in terms of returning to previous hemoglobin A1C levels. What this is telling us is, A, self-management support is effective, but B, as I mentioned before, it needs to be an ongoing process with the patients, constantly reinforced, so that the gains that they make by becoming good self-managers are sustained over time. So how do we make sure that we deliver self-management support in practice? It's going to require a culture change. We're going to have to look at this and recognize the importance of this behavioral intervention in improving clinical outcomes, patient adherence, and patient satisfaction. You can develop training programs. There are no shortage of training programs that are available that incorporate the what's in it for me approach, show the research of effectiveness, develop a return on investment, on saved time and reduce chaos in practice to get your team on board with doing this process. Train staff members to deliver goal setting and action planning, brief action planning to targeted patients after clinical encounters. You don't necessarily have to do this with all patients. Many patients are managing just fine. You don't need to be doing self-management support with them. Quite often what I recommend is you target your folks that are struggling the most with clinical outcomes or social determinants of health that make it difficult for them to care for themselves, and start with those folks first. Ensure that your IT system, your electronic medical record, can track goals and action plans so that when people are talking to patients, they can see what they're working on and check in with them. Dedicate staff time each week to conduct follow-up. And you don't necessarily have to be the ones to do follow-up for everyone, as I mentioned before. But for those patients that you think it's important that you touch base with, dedicate staff time to get a hold of them. And then, as I said earlier, about stratifying patients and target those that are most in need. So the team-based approach to self-management support begins with the medical lead. They must endorse the use of self-management support. All staff need to buy into it and understand the concepts of how it works so that everyone says the same thing to the patient. Recognizing that it's difficult to change practice behavior and incorporate self-management support, so you'll need to practice it, do small tests of change, try it with one patient, see how it works, and slowly build the process into your clinical care system. Assign the responsibility to do it to a motivated team member, someone that would really like to do this work. And then commit to this different visit structure that I talked about that incorporates self-management support. I recommend using simple training programs, learn in small steps, and increase your expertise through action-oriented learning by practicing it. There's all sorts of training programs out there. Some of them are video-based, some of them are off-site. If I can sort of be a bit blunt, this is not rocket science, and so I'm not sure that 3-4-day training programs are necessary, and you don't have the time to take out a practice. So try to track down those small, simple ones that allow you to gain understanding of the concepts, practice it on your own until you're feeling comfortable to start doing it with patients, and then begin building it into your clinical care. I talk about applying the model for improvement in PDSA cycles. That's what I talk when referring to when I say do small tests of change. Try it with one patient one day and then see how you would do it differently. And then cross-train staff for contingency plans. So make sure someone else in the medical team is able to do goal setting and action planning in case someone unexpectedly either leaves the practice or is on sick leave, so that you can cover for them. If you're in a position where you're trying to teach clinicians this process, avoid telling them that they have to do self-management support. It's the same thing as working with patients. Don't threaten dire consequences if they don't do it. I mentioned earlier, don't drag the whole practice out of the office for prolonged training programs that are mostly didactic and not action-oriented. And assume staff is already capable and motivated to deliver self-management support. Most staff are interested in doing this kind of work, and as I mentioned earlier, it increases staff satisfaction. Assuming all training programs work equally may not be the best thing. Check in with your staff and see if these training programs are truly helping them, and if they aren't, move to a different type of training program. So how do we organize the internal resources in the practice as well as the community resources to provide ongoing support to patients? When we talk about organizing internal resources in the practice, walk through the care for a patient. That is, have someone on the team follow a patient around during the course of a visit to find out where there are opportunities to do self-management education and deliver self-management support. We know that patients often wait quite a while in the waiting room. That might be an opportunity for education. Review ideas from the literature and from other colleagues that have built this into their practice. Russ Glasgow, who's worked a lot in this area, has developed a nice paper around opportunities for delivering self-management support, and he has ideas for before the encounter, during the encounter, and after the encounter. We'll take a quick look at those. Before the encounter, what you can often do is, before the patient comes in, do a pre-visit phone contact or email them about the notion of self-management support and what you're going to do. You can do waiting room assessments around what problems are the patient struggling with, that core principle number one of getting the patient to identify their issue. Patient education materials, posters, pamphlets on how to talk to your provider, and how to do self-management support inside the practice. During the encounter, the provider usually reviews the behavioral assessments, gives the patient feedback on their successes and the goals that they're working on, identify priorities for the visit, and target patient education materials to those things that the patient wants to learn about. What we know is that if you take a patient and give them a 1-hour didactic education session or tell them what you think is important for them to know, if it's not relevant to them, they won't remember it. So target that education to the issue that's at hand for them. And then after the encounter, you might want to do referrals to health education. Make sure that the health education people do self-management support and understand the principles of motivational interviewing. You could do phone call follow-ups to see how they're doing, mail more patient education materials to them based on their desire, hook them up with peer support. You might have other people in the practice that they can talk to about their chronic condition, and they can support each other. You can have newsletters, follow-up visits if you need it, and certainly get them to email or internet sites that promote self-management support in an effective way. So I mentioned that there's lots of training programs out there. This is one that was created in Ontario. It's called self-management-toolkit.ca. It's a webular-based modular program. It's free, which is nice. You do have to register and give your email, but the Ontario government doesn't spam you with email. They just want to make sure that they're getting legitimate accounts being set up. It's a combination of text and video training. There's a lot of different resources that you can download from this site. It takes about 2 hours to complete. There's a bulletin board functionality so that you can share your self-management stories with other providers. It's been vetted by a national expert panel in Canada and the U.S., but I do have to say that despite the high volume of users, there has been no evaluation of the effectiveness of the site. There wasn't monies to do that. But you can take a look at that and see if that's something that works for you and your staff. In terms of community resources, there's all sorts of programs that are out there that help patients with self-management support. Probably the best known is the Stanford model, the Chronic Disease Self-Management Program. This model has randomized controlled trial evidence of effectiveness and was developed by Kate Lorg and her colleagues. And essentially, it's a 6-week session. There are 6 sessions, 2.5 hours each, and it's led by lay leaders. And when I say lay leaders, that is someone who is not a clinician but has a chronic disease and has been trained by master trainers to deliver the curriculum of this course. It is a structured curriculum, but it's very action-oriented and interactive for the patients. It can address multiple conditions, or it can be disease-specific. It includes action planning, problem solving, and skill acquisition. And what we hear from patients is it's everything that they wish they had known about taking care of themselves. The RCT outcomes have been improved health behaviors, health status, fewer hospitalizations, and for some folks it has been sustained for 2 years. You would probably want to check in your community to see if the program is being delivered either through the Department of Health or some other clinical system. There's lots of training videos that are out there also. The California Healthcare Foundation has a great video that demonstrates an ineffective interaction between a provider and a patient that is struggling with smoking, and then how to do it properly that incorporates motivational interviewing techniques. University of Florida has great motivational interviewing videos that are also quite effective. So that wraps up the talk on self-management support, but I do want to leave you with a story that I think demonstrates the power of this approach. Many years ago, I was conducting a training with Ed Wagner and our group at McCall, and we were teaching about 50 different primary care practices how to implement the chronic care model. And part of that was doing self-management support. And their homework assignment was they had to go back to the office and the next day try setting a self-management goal and action plan with one patient. And then they were to report back to us at the next session, the next in-person training session. At that next training session, one of the physicians got up and said that he actually wanted to do the process himself so that he could understand it. And he chose a 70-year-old fellow that we'll call Joe, who was struggling with congestive heart failure. They really weren't getting anywhere with his self-care. He wasn't eating properly. He wasn't exercising. He was still smoking. And so the physician explained the process of self-management support, leveled that playing field between the two of them, and acknowledged Joe's ambivalence about change, and asked if he wanted to set a SMART goal, at which point he said yes. And he said, well, what is it you'd like to do? And Joe said, well, you know, my wife died a couple of months ago, or 6 months ago, and I've been feeling pretty lonely, so I want to reduce loneliness in my life. And the physician was thinking, oh, this is, you know, I'm not a psychologist, I'm not a social worker, but, you know, we heard that training that you've got to start where the patient wants to start, so, well, let's try and do this. So he said, is there anything you want to do? He said, you know, I know you like to play bridge. You could join a club, bridge club. And Joe said, no. He said, I know exactly what I don't want to do. I want to go out and buy a puppy. At which point the physician stops writing in the medical record, thinking, I'll never practice medicine again if I write this down. But again, he stopped himself and said, okay, those guys at the training said you got to start where they're willing to start, even if it doesn't seem clinically relevant. So they set a SMART goal. He said, what kind of dog are you going to get? He said, I don't know. I'll have to look and see what's there at the puppy store. How are you going to get down there? Well, I'm going to drive down. When are you going to do it? I'll do it Wednesday. What time Wednesday? I'm going to do it at noon because I'm you know, usually don't do anything around noon. And where's the pet store? So he said, it's this pet store, it's such and such an address. And they agreed that in terms of frequency, maybe one puppy was enough. So he got the commitment statement from Joe. He reiterated that on Wednesday at noon he was going to go down to the pet store and get a puppy. And then they checked confidence. On a scale of 0 to 10, how confident are you? And he said, I'm about a 5. And so they did some problem solving. He said, what's the problem? He said, well, I've never raised a puppy before, so I really don't know what to do. So he said, well, how do you want to solve that problem? And he said, well, I'll talk to the people at the store. They probably have a training program, or maybe there's a book I can read. And so I'll do one of those two things. So again, the problem solving was patient-centered. Joe produced the answer. So the follow-up plan was that the provider would call the patient a week from now to see if he had bought his puppy or not, at which point the provider did do that, got a hold of Joe. He said, how's it going? He said, I bought my puppy. And he said, congratulations. That's terrific. He said, you've taken your first action plan and SMART goal towards reducing loneliness in your life. What's the next thing that you want to do? And he said, oh, no. He said, Joe said, I'm not lonely anymore. He said, this little guy's keeping me really busy. But, you know, he's driving me nuts, but I love him to death. He said, but I did notice that when I take him out for a walk, I get short of breath. Is there anything I can do about that? Now, if you remember what I said about the case study at the beginning, Joe had congestive heart failure, and now what he wanted to do was set a SMART goal around how can I walk the puppy and not get short of breath. So this was the physician's entree into doing the clinical work around managing his congestive heart failure. And we ran into this clinician a couple of years later. Joe has lost a significant amount of weight. He's cut back to almost no smoking at all and is eating properly. And his congestive heart failure is doing considerably better. So the reason I tell you this story is because even though Joe seemed to be starting in a place that was clinically irrelevant and seemed to have absolutely nothing to do with his chronic condition, it helped Joe build his confidence that he could make change in his life and engage in behavior change. And he's been working on his self-management plans ever since on a regular basis. And then on a final note, the one thing I do want to mention, which I should have mentioned earlier, is once you get comfortable with this process of doing brief action planning with patients, and patients understand it and practice it, typically a goal and action plan can be done in under 2 minutes. So time does not become an issue. It may take a little bit longer in the front end to get the patient ready to go, but once they're up to speed and you're up to speed, it's a very effective process. So I urge all of you to start to take a look at Steve Cole's work or some of these other sites. Start practicing it, get comfortable with it. Pick a couple of patients. Don't pick your most difficult patients, but pick ones that are willing to try something new and get used to practicing it with them. And I think that you'll find it a very effective process at improving clinical outcomes as well as improving the interaction between you and your patients. Thank you very much.